Obviously, you're not doing it that first week. So this is my question.
All right. Yes.
So this, like, when I was at home, I was trying to do like the study guide one, right? So these are all.
That was good.
And if it's green, I got them right. So up to 15, I've got them right. But you said to print them off.
Yeah.
Does that mean I have to print off every individual question like this? Or do you want me to just print off?
You should. There should be a box at the top. Or no, there's.
Leave me alone.
There's over here. There's supposed to be a-
Yeah, so if I go to like question 2, it says print, right?
Yeah.
It only lets me print that one question. So I'm fine with printing individual every question, but I was just wondering.
Yeah, go ahead and print every question. That's fine. Yeah,
We'll just do it in black and white. Okay.
that's fine.
So I don't know. I remember taking quiz number 9, quiz number 10 when I was in quarantine. Said missed Friday and I missed next Friday. Quiz number 9 still says it isn't in, so I was confused about that. Quiz number 6, I took because I was in quarantine. Like the only time I was in quarantine was the 9 and 10. So I don't know where that was. I think it feels nice in here.
This afternoon, it was arctically cold in here.
No, I couldn't find them. I don't know. Did we not take them out? What?
Yeah, I remember taking it and I put it in the in the shape of offers and I put it in
Okay.
your slide.
Are you good with me printing out the picture ones like I showed you
Yeah.
and typing this out on the board?
Yeah.
Like I'm.
Yeah. Okay, so quiz 11. Okay, quiz 11.
Quiz 11 I have it.
Quiz 11 is in.
Yeah, no,
Okay.
quiz 9. I don't
Okay.
have it. Just.
Would you like these? My 2 quizzes
Oh,
are missing.
just hand them,
Thank you.
hand them over.
Then lab number 10 isn't it? I don't remember exactly.
Lab number 10, I'm gonna do after I do this.
Oh, okay. I just want to make sure I have everything there. Everything on there.
I'm so tired of looking at this stuff.
I do that all the time.
Oh, wait. Yeah, okay.
When you get back there, can you hand that to Brooke, please? And then this is.
Oh, this is really good.
Thank you so much. I like this microphone.
Natalie.
It's still going through like the quiz that you took through on paper. Because I did 17, I'm pretty sure. I did it on paper and turned it in like a week.
Yeah, I haven't gotten to
Okay.
it. I haven't done any grading.
Does anybody have quiz number 6? There's like nobody.
Marbles, can you see them? Gone, lost them.
We knew that, right?
No, I don't have 5, 6.
Okay. All right, so the way I do review sessions is I don't come with anything prepared. So if you have questions, please feel free to ask them. If you ask me something like, what's on the test? The answer is going to be, I have no idea because I haven't written it yet. So,
Those questions are super.
They're very good. They're
They are.
well,
They're very hard.
I haven't written the test yet. Yeah.
I thought it was a great idea to make your life really. So there's approximately what 120 on the thing that we made.
117. be.
Perfect, so you can just pick 100 out of there and you'll be golden.
Then it saves you time for grading.
Yep.
And actually, they were really good questions. I had to go through the big part.
So that's the one
Yeah,
you
yes.
emailed me.
Yeah.
But I thought you was 117, we study
Read an email
117.
to you.
But you pick 100.
Who sent me the email? Becca did. Is Rebecca Nicholas, right? Yeah. Sorry if I missed this detail. Are we coming to class? No, no, wrong email.
Everything in this is
Oh, here we go.
my legs need to be stretched.
All right, there we are.
Work on the ankle.
Okay, hopefully this will make our lives easier. So, okay, I will go through those. And- Yes.
I'm like, mine does not feel good at all. But still just don't do anything.
Dude, it's so hard to just like do stuff, especially when it doesn't feel good.
Kidneys. Kidneys.
So there's a question on there that
Chapter 12.
We messed it up.
is incorrect, and we know that.
We know that now.
Because we thought it was, I'm sorry, my voice is. We thought it was
Someone was
spleen.
yelling.
Screaming at your teammates to pass you the ball.
Why would it be the spleen as compared to the kidney?
The spleen is important for determining age of red blood cells because the spleen has all those reticular fibers, and the red blood cell has to squeeze in between the reticular fibers, and if it's old, and if it's has a lot of phosphatidylserine exposed to the outside, it can't squeeze between them, and then the reticular cells, which are macrophages or stationary macrophages, they have phosphatidylserine receptors on their surfaces. So if a red blood cell kind of gets hung up and then the reticular cell binds it, it says, okay, pal, you're done. And it phagocytizes it and destroys it. So in terms of assessing the importance of red blood cells and making immune follicles that respond to particular types of infections that where opsonizing antibodies are really important, the spleen is really important. In terms of filtering the blood, when I think of filtering, I think of removing nitrogenous waste and things like that. That's what the kidney does. That's its sole job, is to filter those things from the blood. The liver does an important job filtering blood too. But those organs don't have anything on the kidney. So I would say the kidney is the most important filtration organ. The liver does a lot of other things too. It's not just a filter. The spleen is a lymphoid tissue. So the spleen has follicles, and whatever gets exposed to it, they will make, you'll get follicles of B cells and T cells essentially that are kind of sniffing at this antigen going, what do we have here essentially? So the spleen is very important. That's why people who have lost their spleen or people who have a functionally asplenic, like people with sickle cell disease, people like that, they essentially cannot fight off diseases by encapsulated organisms. So things like Neisseria meningitidis, Haemophilus, Streptococcus pneumoniae, all those. They have to make sure that they are well vaccinated against those diseases. Yes, and by the way, I thought that was a dumb question. No, the question on chapter 12, which one is the best filtration? Or I thought, yeah, I thought that was kind of a dumb question. So
I think I thought it was, I don't know, we were talking about it in our group chat. That was just.
see, McGraw-Hill, if there's a mistake, you can actually enter, this is wrong because then usually within an hour or two, you get an email saying, we're looking at that. And sometimes you get an answer back right away saying, yep, you're wrong, you're right, we're wrong. Other times you'll get an answer that says, we're looking at this, then 5 days later, you get another one, we're still looking at this. Then such and such, okay, yeah. No, we're gonna keep it this way because of this reason, whatever. They're better about it than Pearson. Pearson, if you told them, okay, this is just dead wrong, they'd say, well, our team of experts said it's right. Well, your team of experts are wrong. I don't care if they're teams of experts. Teams of experts at what? Knitting? So, yeah, anyway. So there's my answer to your question. Next question. Oh, on Zoom, if you have any questions on Zoom, feel free to chime in. Can you guys hear me all right? Bree, Jenna?
Yeah, I can hear you.
Okay, all right, good. Your camera's not on, so I can't, you might be making funny faces at me for all I know.
I'm not.
I'll take your word for it. That's it. How does an antigen presenting cell present antigen if it is a class 2 restricted antigen? Somebody walk me through the process. If nobody chimes in, I'm going to call on you. Sure. How does an antigen presenting cell present a class 2 restricted antigen? Bueller? Bueller? Sorry? All right, so PAMPs, what are PAMPs?
Pathogen-associated molecular patterns.
Yep.
Those parts on the surface of the cell that are recognized by antigens.
Right. And so what do white blood cells do with pathogen-associated molecular patterns?
Well, they recognize them, and if they're foreign, then they attack them.
Okay. How?
Phagocytosis.
Okay, phagocytosis is a specific process. You have to bind the membrane before you can undergo phagocytosis. There is no phagocytosis unless you bind the membrane tightly. What does the cell use to bind the PAMP? Okay, the kitty says her. Pathogen recognition receptors. Pathogen recognition receptors. The PAMP says per. All right, then you get phagocytosis. The entity is now inside a phagosome. What happens next? I believe I gave you a handout that had this process on there, unless I'm not remembering that right. Madison, you look terrified. You're thinking, okay. You get this terrified look on your face sometimes. You have to say, I don't have that handout. Or, I forgot that. Or, all right, so the pathogen, antigen, whatever, it's in the phagosome. What happens next? Nope. So that is a pathogen recognition receptor. So it's going to bind. So it binds the antigen, and the antigen might be, part of something bigger, something like that. So that essentially is going to induce phagocytosis. The cell in a cytoskeleton mediated process takes the membrane, ruffles it, moves it around those moving parts of the membrane called pseudopods. And they're going to surround it, and this is going to end up in a vesicle. Inside the cell, that's called a phagosome. What do you do next with the phagosome? Does it stop at a gas station? Does it take up knitting? Does it look for a hamburger? What does it do? Okay, Brooke's shaking her head.
Well, it doesn't do that.
Does it do that? What does it do then? Gets right to work. Good answer. Not quite what I'm looking for. Kind of like the Bible quiz this weekend. People give lots of good answers that were wrong. It's so funny to see quizzers. They'll go, Jesus, sit down. Okay, no. Good answer, not the one we're looking for. The phagosome fuses with a lysosome. Lysosome. You get phagosome lysosome fusion, and you make a phagolysosome. And the lysosome will generate reactive oxygen species, and then there are lots of acid hydrolases that will pick this thing apart bit by bit. But the other thing that gets imported to the lysosome is a cell membrane bound protein that is a type 2 major histocompatibility complex protein. And so this now ends up in the, oh, that's ugly. So put up with my drawings for the semester. You'll have to put up for just an hour or so longer now. So this is in here. These things are getting chopped to bits. So some of these bits end up here. This then gets trafficked out and goes to the membrane where it presents the antigen on the surface. So antigens that are presented by class 2 MHC proteins went through lysosomes. They were part of something that was phagocytized, and then they got chopped up by enzymes in the lysosomes. They bind this then gets sequestered and moved to the membrane.
And that's when the T cell receptor.
Right. And the T cell receptor is going to recognize this with its T cell receptor, and you also need another protein that you need to recognize this with. So the T cell receptor, this is our T cell. It has a T cell receptor, and it has this other thing that will bind to this. You need both of these recognitions. If it's a T helper cell, it's a CD4 protein. If it's a T cytotoxic cell, it is a CD8 protein. And that activates the T cell, and then the T cell makes, especially if it's a helper cell, it makes what? No. makes interleukin 2.
So close, guys, so close.
Interleukin 2, remember, is a T cell activation factor. So this T cell now is going to divide and grow. And then any other T cells that can respond to this in response to interleukin 2. So this will activate itself, it'll grow. This will also activate other T cells as well. Okay?
I'll zoom in, but my dog just ran away. So
You what?
my dog just ran away.
Dog just ran away.
Yeah.
Okay. So the upshot of this is that your things presented by class, first of all, which cells have class 2 MHCs? Antigen presenting cells, which include no. T cells have antigen presented to them by APCs, antigen presenting cells. I mean, Natalie, you're right, antigen presented, just which ones, which cells are antigen presenting cells? Who's the undisputed king of antigen presentation in the body? B cells have class 2, they can present antigen. They're not the major ones though. Who's the big cheese of antigen presentation in the body? Who? Leukocytes?
I'm just
Lymphocytes.
Oh, lymphocytes.
Yeah.
Lymphocytes means B lymphocytes and T lymphocytes. That's what lymphocytes mean. Lymphocytes are a class of white blood cell. The B lymphocytes make antibodies. The T lymphocytes are regulators of the immune response. Dendritic cells. Remember? Dendritic cells. Dendritic cells are the undisputed champions of antigen presentation. The other cells that do a lot of antigen presentation are macrophages or monocytes. Yeah.
What do plasma cells do in that?
Plasma cells are mature B cells that secrete antibody.
So they're further down the line.
Yeah.
Okay.
Yeah. How do you present a class 1 restricted antigen? What cells have class 1? Okay, folks on Zoom, which cells have class 1, MHC class 1? Because these guys aren't giving me any answers, so. If you hear the shuffle of papers, that's what they're doing.
Is it epithelial cells?
All nucleated cells have class 1. All nucleated cells. So class 1 antigens typically come from things like viruses or intracellular parasites. So in the endoplasmic reticulum, particularly in viruses, your proteins that are meant to be expressed on the surface, they're expressed first in the endoplasmic reticulum. And in the endoplasmic reticulum, you have class 1 receptors. So class 1 MHCs, and antigens are imported into the ER lumen by these antigen transporters. These proteins called TAPs, TAP1 and TAP2, transporter of antigen proteins, TAPs. they bind essentially to the MHC. This then gets trafficked to the membrane. Like that. So really, any cell, any infected cell can potentially present a antigen that is class 1 restricted. And then this will be recognized by a T cell or perhaps a B lymphocyte. And if it's a T cytotoxic cell, this will be a CD8 protein. So you need this recognition and you need that recognition too. You have to have the two signals. And then this cell becomes activated. And if it's a T cytotoxic cell, it will actually secrete poisons that will kill this cell, prevent the virus from replicating. That's a class 1 restricted antigen and how it's presented. What is endocarditis? Yeah. Itis. So it's inflammation of the, what part of the heart? Say it again, Caitlin. Valves are coated with endocardium. They're the most susceptible. But it's the endocardium per se. But valves is actually a good answer. Yeah, because that's the part of the endocardium that is the most susceptible. What sort of organisms can cause endocarditis? Give me one set of organisms that cause endocarditis. Strep can, yeah, that causes rheumatic heart. Now, what causes rheumatic heart? What causes rheumatic heart? We went through that in class. Can you remember what causes it? The damage to the valves? What's the mechanism? What's the pathophysiology of how you get acute rheumatic fever from a group A strep infection? What's this protein on the surface? The spiky protein on the surface of the Streptococcus pyogenes? I wonder what protein it is. M protein. M protein is very antigenic. You get a robust immune response against it. Antibodies against M protein cross-react with, Caitlin, go ahead, heart valve tissue. The antibodies bind to heart valve tissue. You activate complement. You get tissue damage that roughens the valve. When you roughen the valve like that, the valves thicken a little bit. You also make little ridges and nooks and crannies where other organisms can potentially hide, essentially. So that can set you up for endocarditis caused by other types of things. What's one source of organisms that can cause endocarditis that you carry around with you all the time? Yeah, Staph aureus, but what else? Go ahead, Bree, you ready to say it? You're all ready to say it.
That's not the right answer. Just continue.
Who cares if you're wrong? I don't care.
I have no idea.
Candida, there are cases of Candida causing endocarditis, but it's rare. It's pretty rare. Viridans, streptococci, and then there's that other group of sanguinus, that's the major viridans strep. Other viridans strep can cause it too, but sanguinus is the big one. And then the HASSIC group. So those all live in your boca, in your mouth. Okay. And if you get what? What's it called? You go to the nice lady with the drill. She's called a dentist. Okay. So in your history, you're going to ask if you've recently had dental work. See? See? You got to know what to ask for. By knowing the pathophysiology, you know what to ask. That's why it's very important that you learn these bits and pieces. All right, how else? Brooke, you mentioned earlier staph. How can you introduce staph into your bloodstream? Open wounds, yeah, definitely. Open wounds, especially burns, especially deep lacerations. Yeah, absolutely. What's another one that's really common? They can affect, okay, artificial heart valves, yeah. Artificial heart valves will be colonized usually by organisms that make biofilms. And Miss Caitlin, can you name me a biofilm making organism that can affect an artificial heart valve? Oh, pat yourself on the back. You're so smart. Yes, very good. Very good. That's one of them. Pseudomonas aeruginosa being another. That's not quite as common. But how is staph going to get in your blood like that? What sort of things can staph infect? Makes biofilm so it can infect catheters. Catheters and frankly, any implant. So Natalie, you started this, so name me what kind of catheter someone might have. Okay, urinary catheter. Yeah. What else? Central lines. Would that be one way that can infect something and make a biofilm? Sure. How about PICC lines? Some people call PICC lines ports. A PICC line can be a port if it's open and you can use it to. People who get chemotherapy will get ports. And it's essentially, it's a removable, it's the PICC line where the tube is removable. Any of those sorts of things essentially the organism can colonize it via biofilm and then they get in the heart. And especially if the heart is roughened, the valves are roughened, you can get infection of those valves. All right, so you infect the heart valves and they can cause these growths on the valves. What do you call those? Vegetations. Vegetations. Caitlin is leading you guys in the dust. Come on, you guys need to pick up the pace here a bit. And those vegetations can break off and become what? Septic. Caitlin, you said it. Emboli. Septic emboli. And they can cause, what is it called? When they get blood vessels, they're called, sorry? They can plug vessels and cause infarctions. So if you have one in your noggin, that's called a stroke. Thank you. Stroke. Or maybe I should have done this. Or this, stroke, yeah. Sounds like, yeah. Okay, now if the embolism breaks off on the right side, what's it more likely going to cause? Pulmonary, what's it called? Embolism, pulmonary embolism, PE, physical education. And if it breaks off on the right side, left side, that's going to be more likely to cause a stroke. All right. What sort of organisms, well, let's put it this way. Who's at high risk for infective endocarditis? For bacterial infective endocarditis? Give me some people who are at high risk. Diabetics, yep. People who are immunosuppressed, sure. Say again? Older people, especially if they have the roughened heart valves. Yeah, older people, definitely. Who else? For certain bacteria, yeah, if they get infected with group B strep, then yes. Although group B strep is more likely to cause meningitis, but it can cause endocarditis in neonates. So yes. How do infants get infected with group B strep? Through the birth canal. Good. So that means who has to be infected? The mother. So let's say you work labor delivery. On a chart, bless you, mom's not been screened for group B strep, so you're going to get her screened for group B strep, because if she has group B strep, soon as junior comes out, or junior S or whatever, that kid's going to need to go on antibiotics ASAP. Essentially, it's a good time to hand stuff back. So, yes, that was the one I was trying to do that out. So you guys are going to have freaking flyers, and some of them are going to be IV drug users. They are at increased risk, especially if they reuse needles. That's why some of these towns, the hospitals, are implementing needle exchanges. So if you're going to use drugs, you can use them safely. Some have criticized that policy. I think the policy has its merits. It has its caveats, definitely. But it's part of this policy called risk reduction. And risk reduction, the goal is to try to keep people out of prison who frankly would do better if they had medical treatment. So that's the strategy behind it. IV drug users, good. What are some symptoms of endocarditis? Say again? Oh, Osler's note. What are Osler's notes? Where do they appear? Fingers and toes. Do they hurt? Yes, they smart big time. If you push on them, are they soft or hard? Hard. So they, what causes them? Hey, Jenna.
I don't know the answer.
You don't know the answer?
No.
Can you look it up?
Yeah, I can look it up.
Okay, then look it up.
I'm working on it.
You guys
What is
think you're
it called
getting off
again?
easy.
What is it called?
Osler's nodes. Endocarditis. Do you have those notes in front of you?
Yeah. So they're painful red raised lesions found on the hands and feet.
Yes, all
um,
correct. But what causes them?
Immune complex deposition.
That's absolutely correct. They're the result of antibody antigen complexes that settle out in connective tissue. And they activate complement and they cause inflammation because they'll attract white blood cells because you get these complement fragments, C5, C5a, C3, so on and so forth, that attracts blood cells. That's what that it's a lot of tissue damage and it really hurts. So that's an Osler's node. What are the flattish painless ones that you get on the palms and feet? What are those called? Janeway lesions. Janeway lesions. Good. Good. What else? What's the patient comes in and tells you they feel X. What are the things you're going to look for endocarditis? Splinter hemorrhages, yeah. Splinter hemorrhages as well. Fever. There's like 3 main symptoms. Fever is a biggie. What else? Heart murmur. And usually it's a new heart murmur, or the murmur that they already have is getting worse. So you might have to send away for medical records. And if they don't have medical records, you may need to order an echo, because the echo usually will be able to tell you if the valves are inflamed. Okay, fever, heart murmur, what else? Chills, fatigue, although some people may not have that. But the fever and the heart murmur, usually everybody has that with endocarditis. Maybe. Is that one okay? Oh, low blood pressure. Yeah, probably. Probably low blood pressure. Their heart might be beating faster. Consequently, they will probably be huffing and puffing as well. That's another feature. So yeah, all those things are good symptoms. Okay, treatment. Treatment. This one you can let it go. It'll go away by itself. No. You treat this and you treat it in a hurry. So if the culprit is Staphylococcus aureus, your choice is
it penicillin?
not for Staph aureus, Jenna. No. Staph is resistant to most of your penicillins.
Is that for endocarditis though?
And for endocarditis,
It says antibiotics and penicillin.
Say again, Jenna.
It says antibiotics and penicillin for like medications.
I said penicillin.
No. I looked it up.
Oh, you looked it up.
Yeah, I cheated.
If your organism, if there's a high probability it's Staphylococcus, you wouldn't touch penicillin with a 10-foot pole. It's resistant.
Okay.
That you set yourself up for treatment failure. So that source is probably outdated, or it's just plain old wrong. You'd get a culture, but you usually don't want to wait until the culture grows, see if it's methicillin sensitive or methicillin resistant. So you usually just go straight to vancomycin, is usually what you do. So go to vancomycin, then if the culture shows that it is methicillin sensitive, then you usually would go to a staphylococcal specific penicillin like dicloxacillin or nafcillin or one of those, oxacillin. Staph is resistant to ceftriaxone, so you wouldn't use ceftriaxone. Ceftriaxone is better for gram negatives. What if the culprit is Streptococcus sanguinis? Then what you going to use? In that case, you could use ceftriaxone, actually, because that one is usually susceptible to ceftriaxone. Some people will go to vancomycin. That might be overkill. Or you might start with vancomycin and then transition to ceftriaxone in cases like that. Because with empirical treatment, you don't want to wait, usually, because your patient will usually get worse. So you just treat with something that you know will work. How about if the culprit is, say, gram-negative bacteria? Then what are you going to usually use? You can use ceftriaxone. In a case like that, you'd probably use something like amoxicillin with clavulanate. If you use the beta-lactamase inhibitor with the beta-lactam, then that would probably work a lot better than just straight amoxicillin. Amoxicillin by itself has trouble penetrating the cell, and so you need to give it a bit of help with the beta-lactamase inhibitor. So it depends. If it's Pseudomonas, then use anti-pseudomonal drugs in cases like that, which include things like ceftazidime or cefepime or monobactams in that case, or a fluoroquinolone. Fluoroquinolones are pretty reliable with Pseudomonas. Okay.
Go through what we're kind of just doing, like what penicillin is best used to treat and what each of the main APIs.
You sure? So penicillin G is the treatment of choice for neurosyphilis. And if you're sensitive to penicillin, if you have a sensitivity to it, an allergy to it, many neurologists will say, I'm going to put you through a desensitization protocol and then still give you the penicillin just because penicillin works the best for neurosyphilis. The other thing penicillin seems to work pretty well for is group B strep infections. So group B strep infections are still largely sensitive to penicillin. There are some strains of Neisseria meningitidis that are sensitive to penicillin, but it would be a cold day in the Sahara Desert before someone would treat meningitis with penicillin on the off chance that the strain with which they're infected is resistant. They would go straight to ceftriaxone usually. So amoxicillin is good for certain types of sensitive strains of some gram-negative organisms. Some Haemophilus strains are sensitive to it. Some enteric bacterial strains are sensitive to it. For things like sinusitis, it's usually combined with clavulanate, so augmentin, that is usually used for sinusitis. So that's your aminopenicillins. Ampicillin is a drug that has to be given usually parenterally. There's not a form of ampicillin that you can give orally. Ampicillin is still actually given for certain types of gastrointestinal infections. Ampicillin is also combined with a beta-lactamase inhibitor called sulbactam. The name of that drug is Unisys, UNASYS, Unisys. That is used for really resistant gram-negative bacteria like Acinetobacter and things like that. The anti-staphylococcal penicillins oxacillin and dicloxacillin and nafcillin. They're used for methicillin-sensitive Staph aureus infections. If you have MRSA, your go-to is vancomycin. And if vancomycin doesn't work, or if the vancomycin sensitivity of the organism is low, so you need to use a lot of vancomycin, then you have other options. You have things like linezolid or tedozolid or ceftaroline, trade name Teflaro, that's a 5th generation cephalosporin. And there are some other newer glycopeptides you can use too, telavancin, drugs like that. Those drugs are not widely used. Daptomycin, I don't know if I talked much about daptomycin at all. Daptomycin is very good for gram-positives if used topically. It's not very good for your kidneys, so you don't use it systemically, and you don't use it for respiratory infections because it's inactivated by respiratory surfactant. Then you have the anti-Pseudomonas penicillins. And of those, ticaracillin is really the only one that is used, at least in this country. Carbenicillin is only used for urinary tract infections. Because of the way it's secreted, you only get high enough concentrations in the urinary tract. So those are your penicillins, your cephalosporins include your first, second, third, fourth, fifth. The first generation ones pretty much are effective against gram-positives. They're largely not effective against gram-negatives. The second generations have more activity against gram-negatives, so they get used a lot for pre-op. If someone's going to have GI surgery, they get prophylactic antibiotics, for example. Second generation cephalosporins get used a fair amount for that. They're also used for skin infections, like if you get an outer ear infection because of a earring or something like that. Second generation cephalosporins are pretty commonly used for stuff like that. They're also used for blepharitis. You guys remember what blepharitis is? Oh, okay. Some of you are nodding. Okay, blepharitis is eyelid infections. Eyelid infections. Yeah. Right. Blepharitis. Third generation cephalosporins are largely used against gram-negative bacteria. They have good activity against gram-negative bacteria, and they penetrate the blood-brain barrier very well. That's why they're used for meningitis a lot. Ceftriaxone is probably the most heavily used drug out of that group, but you never use ceftriaxone in babies. It causes biliary sludging. Use cefotaxime instead or something like that. Fourth generation, cefepime is a very good drug for Pseudomonas or for very drug-resistant enteric bacteria. It's a good drug for that. And the fifth generation, ceftaroline, is a drug that's very effective against MRSA, and it's also effective against other organisms too. Those are cephalosporins.
So for MRSA, isn't the main treatment like vancomycin?
For MRSA, the main treatment is vancomycin, but you have other options if that doesn't quite
But
work.
like on the test, it's like, what is the treatment for MRSA? It's like cephalosporin, vancomycin.
It'd be vancomycin because that's where you go first, unless you have good evidence that your strain is vancomycin resistant. Then the carbapenems are very, very broad spectrum. So imipenem and doripenem and ertapenem and meropenem and so on and so forth. Remember, ertapenem is not effective against pseudomonads. The others are. Remember that imipenem has to be given with cytostatin. Otherwise, it damages your kidneys. So that one is a combination, always imipenem, cytostatin. And then the one monobactam is aztreonam. Aztreonam is very effective against pseudomonads. And there's an inhaled form that's used for people with cystic fibrosis, since they tend to get a lot of pseudomonas pneumonias. And that inhaled form is called Cayston. Cayston. C-A-Y-S-T-O-N. Cayston. And if you guys do family medicine or if you do peds, you'll probably come across kids who have CF, and you'll have to deal with their respiratory infections and their GI issues and things like that. And it's a challenge. It's a challenge. So that's the beta lactam group. Do you want me to keep going? No? Okay. Oh. Okay. Yeah. Pneumonia. Physical exam. What sort of things you're going to hear on pneumonia? Oh, liquid. What's the characteristic about liquid? Rebecca, how come we have a name tag on?
Sorry, I was at another class.
Oh, okay.
And I had a presentation.
Oh, okay.
Yeah, in case you forgot my name.
Oh, okay. Okay, sound. What about sound and liquid? Does sound travel slower or faster through liquid? Faster. So what sort of things do you do a physical exam? What sort of things you're going to see? Okay, percussion. There's a dullness to percussion. It feels different, doesn't it? Yeah. It's got a different feel to it. Once you see it, you can't miss it. You can't miss it. What else? Tactile fremitus. What's tactile fremitus? The vibrations of the chest when they speak. Instead of getting just the usual soft, you put your hand on there, you're going to have them say something resonant like 99 or blue moon, and the chest is going to really rattle. It's going to rattle quite a bit. Then when you listen over the area of consolidation, what's it going to sound like? Crackles, and also the passage of air through the bronchial tubes, through the airways, will be very, very loud, be very clear. And when they speak and you go over the consolidated area, the sound gets louder. That's called bronchophony. These are all features of pneumonia. What's the number one cause of pneumonia in people over 40? Come on, CNAs. Some of you CNAs out there, you've seen this before. Influenza is up there, but it's not the number one cause. No, no. In hospitals, that's a type of hospital-acquired pneumonia. Strep pneumoniae, there you go. Caden is blowing you guys out of the water. Holy Moses. She's one of those sleepers. Streptomoniae. How about at the other end of the spectrum, the other end spectrum of age? What's the RSV? Streptomoniae? Chlamydia? Babies, we're talking about babies. E. coli. E. coli, definitely. E. coli is a denizen of mom's GI tract, and the kid usually gets inoculated with E. coli when they're born, and their normal flora is not such that they can ward off the E. coli. So the E. coli colonizes the respiratory tract and makes a mess of it, shall we say. After about 4 months, usually not the case, but E. coli is definitely one of the main causes of pneumonia in neonates. So we have RSV, we have Streptomoniae, we have E. coli, anything else? And chlamydia and chlamydophila. Group B strep, yes, if the mother is a carrier. What's the difference between a classic and an atypical pneumonia? Atypical typically does not have a fever. Good, very good. Might have a fever, but most often it usually doesn't. Patient usually has a, what's it called? Right, non-productive cough. They usually don't have a fever and they're not all that short of breath. Maybe a little short of breath. They may have some chest pain when they breathe in and out. Classic pneumonia. What's the signs of classic pneumonia? Dyspnea, which means shortness of breath, fever, productive cough. That stuff that comes up is called sputum. The sputum is made from what? The exudate in the alveoli of the lung, right? You said it, alveoli, good, good medicine, good. Is that sputum informative at all? Does it tell you anything about their disease? Yeah, it does. You look at the color. What kind of color should it be or not be? The darker it is, the more protein it is, the more inflammation you have. And if it's streaked with blood, that's bad. That's bad. We didn't talk so much about tuberculosis, but with tuberculosis, if it reactivates, tuberculosis tends to begin in the lower lobes of the lung. When it reactivates, it tends to go to the upper lobes of the lung, and it can tear up the lungs pretty badly, and it can form cavities in the lungs. And the formation of those cavities, with all that damage, it erodes blood vessels, and you get this thing called hemoptysis. If any of you have ever seen the movie Tombstone, Val Kilmer plays Doc Holliday, and Doc Holliday had tuberculosis, very advanced tuberculosis, in fact. And he plays that part to a T, but it shows you essentially the degradation of the person that occurs as tuberculosis essentially just slowly eats them from the inside out. That's why the disease was called consumption. In fact, if you're into opera at all, there are several heroines in operas who die of consumption. So La Boheme, the heroine, Mimi, she dies of consumption. She dies of tuberculosis. And then La Traviata, the heroine, she dies of tuberculosis. So tuberculosis was a very prominent disease. And standing up and reciting poetry while you coughed into a handkerchief and your blood came up, essentially, that was very accepted at one time. And then we got rid of cuspidors, and that helped, and started pasteurizing milk, and that dropped tuberculosis rates a whole bunch. Ventilator-acquired pneumonia. What's the biggest cause of ventilator-acquired pneumonia? VAP. It can. Pseudomonas makes biofilms. And so it can be. It's not the number one cause. What's the number one cause of VAP? That's Pseudomonas aeruginosa. It is a cause, staph, right? Staph aureus. Staph aureus, and in hospitals, very often MRSA. Very often methicillin-resistant Staph aureus. So when someone's been on a ventilator over 48 hours, their risk for VAP goes up. So you need to be watching them. Yes. Not as well as Staph epidermidis, but it can make biofilms, yes. Some strains especially. What's the biggest cause of aspiration pneumonia? Klebsiella, good. Klebsiella pneumoniae, very good. Yes, exactly right. Klebsiella is usually very drug resistant, very hard organism to treat. And that can also disseminate and cause meningitis and nasty, nasty critter. The other one is an extremely drug-resistant organism called the Acinetobacter baumannii, which is resistant to pretty near everything that's out there. So just pray your patient doesn't get that one. Other questions? Which organism causes food poisoning that comes quickly and leaves quickly? Nope. Starts with C, Clostridium perfringens. Oh, Clostridium difficile? That doesn't cause food poisoning. That causes pseudomembranous enterocolitis. Staph aureus. Staph aureus. Some strains of Staph aureus make an enterotoxin. So this is not an infection, it's a toxicosis. But Staph aureus, food poisoning, it's usually somebody with unwashed hands. You get it quickly, it leaves quickly. That's Staph aureus. So somebody making your pizza, they didn't don their gloves, they've got staph on their hands. You don't wash your hands after handling something, you prepare something, you eat it. Oh gee, and oh gee, I feel better now. Probably Staph aureus. Which food poisoning usually occurs in canned goods and can cause a flaccid paralysis?
Botulism.
Very good, Bree. Botulism, exactly right. Okay, Bree, since you're so smart, let's see if you know this one. What kind of canned goods will have Clostridium botulinum?
I'm not sure.
I'm not sure. Brooke is waving her hand around like she knows something. So
I'm not sure if I know, but is honey one of them?
honey will cause infant botulism. Doesn't tend to cause botulism in adults, but it will cause botulism in infants. In that case, the Clostridium botulinum colonizes the GI tract because the normal flora is not quite established yet. So that's why even if the honey has Clostridium botulinum spores, if they germinate, they don't gain a foothold. They die very quickly, so they don't make enough toxin to hurt you. So it's usually canned good, like canned pears, things like that. Not so much tomatoes, because a lot of the tomatoes now are these very low pH tomatoes, and that low pH will prevent botulism from becoming established. But if anyone does any home canning and then the cans start to get distended at all by gas production, that's a good indication you should need it. You've got organisms in there making gas. Do you have your hand up? Rebecca? No? Okay, I thought you had your hand up. Okay, so botulism. Which organism makes the two-phase food poisoning early and then a little bit later? About an hour or so first, and then about 12 to 17 hours later, you get another bout because it makes two toxins. No. That's a good guess, though. Bacillus cereus. So you get sick the second time, you say, oh, be serious. Okay, it's stupid, but if you remember it, you remember it. Perfringens is usually about 12 hours or so, 12 to 20 some odd hours after you consume a contaminated food source. And it's usually food that's been contaminated with soil of some sort because the organism is found largely in soil. So that's why you should not observe the 3-second rule. Not a good idea. Because people walk in the soil, they come in here, they track it in here, you drop it on the floor, you may get organisms on there and it might be Clostridium perfringens. Now, I'm not saying it will happen, but could it happen? Yeah. So you want to minimize your risk. So. Which organism causes copious amounts of diarrhea that can dehydrate you within a few days? No, although Campylobacter can give you a pretty bad case of the trots. It won't dehydrate you that fast. There is one, though, that will. No, cholera. Cholera. Speaking of salmonella, there's two types of salmonella, right? There's typhoid type, the typhoidal, and the non-typhoidal. Non-typhoidal tend to make more of a GI infection, where you get inflammation of the GI tract, but you don't get invasion. So you can have bad diarrhea, you can feel pretty lousy, you can have a lot of GI pain, but you don't usually have bad diarrhea or anything like that. Typhoid, the organisms invade the gut and invade the bloodstream and can cause extremely high fevers. How high? 104 is not unheard of. And so the patient, when you get fevers that high, the patient starts to get loopy. Very, very loopy. Okay, Mrs. Gibbons lives at a retirement home. Her husband died 10 years ago. She has a touch of diabetes that she controls with diet and exercise. She walks the halls of the rest home 3 times a day, faithfully. You can set your watch by her. She takes metoprolol, beta blocker for high blood pressure, and she's on atorvastatin for high cholesterol. Her family comes and sees her often. She's in otherwise good health. She wears glasses and she wears hearing aids. You find her wandering the halls late at night looking for her cat, which she does not have. This is out of character for her. You put her back to bed. And then the next day she calls you her daughter, which she's never done before. What did you screen her for? UTI.
UTI.
Very good. UTI. It's the most common cause of UTIs. No. E. coli. E. coli. Candida will tend to cause vaginitis. It can cause cystitis. It usually causes cystitis in immunosuppressed people. In not people with healthy immune system, doesn't usually tend to cause cystitis, more vaginitis. The most common cause of cystitis is E. coli. And then in sexually active young females, the second most prevalent cause is Staphylococcus saprophyticus. So Mrs. Gibbons has a UTI. What do you give her? You're the nurse practitioner in this place. You got to write her a script. What do you give her? That's a good choice. That's a very good choice. Concentrated in the urine, well tolerated, won't interact with her other meds, which for elderly people, you need to really watch those interactions like a hawk. Yeah, that's an excellent choice. Excellent choice. Sorry? She's taking metoprolol and atorvastatin, and she takes a multivitamin too.
She said that she could take one though.
Nitrofurantoin, nitrofurantoin, which is a very good choice.
It also says then the nasal purity.
If she has pain, which a lot of older people with urinary tract infections don't have pain. So that one you could actually drop out. Younger people, when they get, especially, you guys do women's health at all? There's this condition, there's this phenomenon, it's called honeymoon cystitis. Have you heard of that before? Okay, you've heard of that. Let me be tactful. Some women, if they consummate their relationship on their honeymoon, like the Bible says you're supposed to, their body just isn't used to intercourse yet. And so organisms from the perineum get dragged into the urethra. And so soon after their first intimate experience, they get a bladder infection, even though their last bladder infection might have been 10 years ago. And that's called a honeymoon cystitis. And it's really common. And if I can be a little bit crass, and if you forgive me, I'm going to guess that a proportion of you in this class will probably experience it. So if it happens, don't beat yourself up. Happened to my wife. And she's like, what's wrong with me? I never get bladder infections. Sorry. It's fine. You can blame me. Just have, the thing is, some women that happens to them, and that usually the bladder infection really hurts because they haven't had them before, and they get this raging inflammation. And they might not even have that thick an infection. It's just the bladder is not used to being infected. So it just really says, oh, are you going to infect me? Well, I'll show you. And there's pain, and there's dysuria, and so on and so forth. So yeah. The beauty of that, if you treat cystitis, you treat it quickly, it usually is very effective, goes away usually quickly, because the drugs that are used, they're excreted by the kidney, so they achieve very high concentrations in the urine, and so they tend to kill the bacteria quite quickly. The other good drug for a bladder infection would be the sulfa drugs. Sulfamethoxazole, trimethoprim, so-called Bactrim, or cotrimazole, as it's sometimes called, since sulfamethoxazole, trimethoprim doesn't really move off the tongue very easily. Yeah, man.
So when would you take, like, give a patient Irene?
If they're in a lot of pain, and if they're not on anything else that'll interact with it. That drug, fortunately, doesn't interact with a ton of other things, but it does interact with a few things.
Is that like the last resort?
No, not at all. It's just if someone has a lot of pain, and if they have a lot of swelling, the sphincter might swell shut, and then they got to get catheterized. And so by relieving the pain, some people, when they get a bladder infection, they become incontinent. That can be really embarrassing. That can also relieve the incontinence as well. So that's when you'd use that. Some physicians prescribe it all the time. Others like, nah. Once you give them the drugs, the pain will go away usually pretty quickly, which is usually the case, but some people don't. They've got lasting pain. So, and having pain, you need to go to the loo. I mean, that's drag, right? So that's usually when you give it. It's not, it's a drug that doesn't have a long half-life. So it doesn't stay in the system for a long time. So you can just take it when there's an issue. And usually too, the pain will decrease to where you don't need it. And again, it's going to depend. Some people have high pain tolerances, some people don't. Some people might come in with a bladder infection, just be doubled over, like, ow, 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 it hurts, make it go away, you know, so on and so forth. Others like, oh, you know, this is kind of annoying. It's just very individual. So, honeymoon cystitis. But treat bladder infections. They can get worse. They don't go away on their own usually. And if you get scarring of the bladder or scarring of the ureters, that's not good. That's not good. What do you use to treat tularemia? That's the one you get from skinning rabbits and. Sorry? They're pretty resistant, so you use intravenous gentamicin. Intravenous gentamicin works quite well against Francisella tularemia. Tularensis, sorry, tularensis. Okay, any more questions? Yes?
So I wasn't here when everybody asked, but what did you say about using the questions that we made?
Oh, I'm going to use them. Yeah, definitely. Oh, yeah.
Did you look at them?
Yeah.
Did they look good?
Most of them, yeah.
Did you see that there was a section on the bottom that had extra questions?
Mm-hmm.
Okay.
Yeah.
Just making sure you do that.
Yeah, no, I will use them definitely. Some of them, even the ones I don't like, I can tweak.
Okay.
They don't need, but a little bit of tweaking can cover a multitude of sins. So, yeah. No, you guys did a good job. You should congratulate yourself. Also, by writing questions, you probably noticed how much helped you study. So, I had a prof. So when I was at UC Davis, I was the TA, one of the TAs for the med micro class for the medical students. We had to make all the media and then we had to run the lab. Some of the dumbest people I've ever met were medical students. I'm not kidding. Just, God. People very good at taking tests, but just in terms of practical knowledge, practice, common sense, they were just as dumb as a post. And anyway, this guy, Howard Beeman, he said, one of your assignments is that you guys have to all write 10 questions. The assignment is 100 points, and you have to write 10 questions. You get a point, 10 points for every question, and I'll subtract points for mistakes in the question or, you know, whatever. So that was his assignment. And the students who were in the library, you could see them back there. They were writing questions and giving them to each other. And they were digging deep into the books trying to say, well, no, that's not actually right because it says here that underneath, because I said, man, that was a good assignment. When he gave them that assignment, all the students just kind of rolled their eyes. And the assignment really forced them to study and study hard. So I think that's a good way to help you study, is to write questions. For my Bible quizzes, I tell them, write questions, because help you think about the material and how to, you know, when our high priest came for the good things that were to come, he did not enter a temple made with human hands. That is not of this world, but he entered not by the blood of goats and bulls, but by his own blood, and thereby purchase eternal salvation for all those who believe in, so on and so forth. Being able essentially to break that down and say, okay, our high priest came for the what? Who came for the good things yet to come? You know, trying to do that really helps them engage with the material. So I think it does the same thing for something like Med Micro. So, all right, and I will see you all Wednesday. Study hard, make me proud, And again, I can't emphasize this enough. Thank you so much for being such a great class. You guys have really been outstanding. So did you feel like you learned something? Okay. Example of how I would tweak a question. Well, let me call up one of them.
So I have this for you. Sorry I didn't give it to you earlier.
Oh, okay.
Thank you.
Yeah. Okay, let me go here and, okay, where's Rebecca's? Here's Rebecca's.
The 62 mini thermometer.
Someone told me Ryan Frost is not the women's basketball coach anymore.
He resigned 2 weeks ago.
Who is?
I don't know if we're like allowed to say. I mean, I guess that we have a game tomorrow. Tyler Hughes.
I don't know him.
Well, he's the new, interim.
Was it like a forced resignation or was it? Okay. Of course, they don't tell you guys anything, but which is probably a little annoying.
Yeah, it is.
I mean,
It's just only what we've heard from other people.
that sucks.
Yeah.
And the fact that he was your coach and like you guys probably were, I mean, you probably talked to him a lot too.
Yeah,
So it was
yeah.
like, what just happened? Like, you
Yeah.
just left us
No, it is.
stranded.
It's definitely like.
Well, too, I think, okay, this is the way I think. I don't have the confidence you probably have, but I would just kind of say to myself, okay, well, what did we do? What's wrong with us? What did we do? Okay, so, okay, all right, so, okay, folks on Zoom, I'm gonna share this so that you guys can see what we're talking about. All right, so here's the questions. All right, which of the following is a macromolecule that assembles into bilayers? Protein, carbohydrate, lipid, nucleic acid. Okay, lipids actually don't organize into bilayers. It's actually phospholipids. You need something that has hydrophobicity at one end and hydrophilicity at the other end. It has to be water loving, water hating. That's why it assembles into a bilayer. Also assembles into bilayer in what? In oil, in water. And so that question, in order to make it clear, we should say in an aqueous environment or in water. And then instead of lipid, it should say phospholipids. Phospholipids. That would be a better way to say that.
Because I was reading that question this morning, just going through them. And I was like, I understand how it could be a lipid because of the phospholipid bilayer, but that's
Yeah.
a very broad spectrum.
That's why I was talking about the one on the group chat, the one
He
about.
talks about it, it's a kidney.
Yeah, and I was like, I just figured that was a very broad question
Yeah.
for something in micro. That's something like out of figure would have been more in depth.
Yes.
I wasn't saying it was a bad question,
No.
like I got the question,
Yes.
but yeah.
Okay, this
And
question
I thought the
here.
same thing when I read that question. I was like, because my fiance was texting me and I was like, oh, it's the kidney. And he was like, nope, it's the spleen. And I was like.
See,
they
I
both do,
I
like-
thought of, like,
That's
the
a-
spleen
I don't
and
like that
blood.
question.
The blood is like the
I don't like
reservoir
that
of
question.
this-
Yeah.
in that case.
Because in
It's
the-
Okay, now this question here, which of the following correctly sequences the protozoan life cycle? And it's got all these things. That's a really good question.
Yeah.
That question doesn't need any tweaking at all. I would use that question completely as is.
How about anything from chapter 17? Or
Oh,
chapter 2?
okay, let's go down to 17
But I also.
here.
I
All
got
right.
questions.
Yeah.
Damage to blood vessels caused by cytokines released by the white blood cells. Boy, there's a lot of clauses in there. Leads to vascular collapse, hemorrhage, and crops of petechiae.
I did write that one.
Okay, first of all, it's a run-on sentence, so it needs some grammatical help.
I never said how.
But all of those are clearly, that's clearly Neisseria meningitidis. What you described there, and each one of these organisms can cause meningitis. So first of all, I fixed the grammar. Secondly, I'd say, out of these organisms that cause meningitis, which of them have these particular features? Petechial rash in the skin, the hemorrhages, vascular collapse. Petechial, petechiae, yeah, yeah.
I always say it wrong.
Yeah. Because that is actually also caused by antigen antibody complexes that get stuck in the small capillaries of the skin, and they cause infarctions, and you get these bruises in the skin. That's essentially hemorrhaging vessels. Also, the endotoxin, the LPS, also causes that as well. That causes a lot of damage as well. Which of the following is incorrect regarding Clostridium tetani? It's cause of tetanus. Yep. Forms endospores. Yep. Gram-negative. Nope. It's gram-positive. Releases tetanospasmin exotoxin. Yep. That's tetanus toxin. All right. Brain and spinal cord are made up of neurons, meninges. Well, their meninges surround them. Ganglia. Ganglia are actually part of the spinal cord because their cell bodies are in the spinal cord, but they extend axons into the ganglia. So you could say that the ganglia, also there are ganglia, the basal ganglia are in the brain. So blood, well, blood goes into it. It's not really a part of it. So that one would need some tweaking. That one needs some tweaking. Neisseria meningitis is, it's not a gram-positive diplococcus, it's a gram-negative diplococcus. That answer is wrong. That's question 4 from chapter 17. So this particular one is wrong. You just have to essentially change that to gram-negative, like that. Now it's perfectly fine. See, tweaking.
Which one? Chapter 17.
Number 4.
Right. Meningococcemia. Best treated with ceftriaxone penicillin or cefotaxime, all good choices. Associated with high fever, vascular collapse, hemorrhage, and petechiae. Started from a nasopharyngeal infection, usually, yeah. Caused by a gram-negative diplococcus. Now there you got the gram-negative right. All of the above. Yeah, that's pretty good. I could use that one. Serological testing on a patient's cerebrospinal fluid confirms a diagnosis of polio. Okay, serological testing, you're not really going to do serological testing on the CSF, you're going to do serological testing on the blood. So that would need some fixing.
So it'd be serological testing on the patient's blood.
Yeah.
Confirms the diagnosis of
Right.
polio. What's the best treatment?
Yeah. What's the best treatment modality? Unfortunately, there's no medications for polio, so just respiratory support, yeah.
I always remember the answer to that one because there's a guy, I seen it on like a video of him, the iron lung.
Yep.
Because like he had polio or has polio.
Yeah, it's
And-
the picture in the book.
Yeah.
Our book has a picture of,
There was,
okay.
well, there's that, but I've also seen the video.
Yeah, I've seen the video of him like talking and stuff.
Yeah.
I thought that's
It's
crazy.
insane.
Like how he like.
It's so
It
sad.
is so
Yeah,
sad. Like
how
he
he
literally
lived
has
his
to
life.
just, yeah.
Yeah.
Sits in there. and-
That's why we wheeled an iron lung through campus when I was a student.
Wow. What would they do now? They would just have him up on a ventilator, right?
Probably.
So how come they never like transitioned him from the iron lung to like a ventilator?
Because if they're on a ventilator, they can't talk. Also, their chances of pneumonia are a lot higher.
Okay, that makes sense. Yeah,
And what's
On a ventilator, you can't cough and clear.
yeah.
That's the other issue with the ventilator.
You would think that would be hard with an iron lung though, because you're always horizontal.
Yeah. They, I think they do get them up and, yeah, I'm not
Is there
sure.
a lot of people that still use those?
No. With the advent of polio vaccination, the number of people who need to go on iron lungs now is infinitesimally small, very small.
Is that the vaccine that everybody talk, or is that the measles that everybody associates? with
Measles,
polio?
mumps, rubella is the one that people think mistakenly is linked to autism. Polio vaccine, as far as I know, has never been linked by anti-vax groups to autism. I had this conversation with this kid at a quiz once. There's a homeschool group up in Lapeer, Michigan, and they they go to the Lapeer Free Methodist Church and several of them quiz, and they are pretty staunchly anti-vaccine. And this kid told me, I won't get vaccinated because you're putting chemicals in your body. I said, well, what did you do at lunch? And he went, well, that's different. That's food. I said, no, it's not. It's chemicals, proteins, carbohydrates. Well, but you're putting vaccines in your blood. What do you think happens to the food? It gets absorbed by the GI tract and goes into your blood.
That's such a good like thing to say. My fiance's stepdad always like he doesn't say anything straight to me, but like he just says had a lot to say about like the COVID vaccine. Like, and he knows that I'm like fully vaccinated. And it's like I don't know how to like say to him, like, because he just has so much negative stuff to say about it. And like, I don't know, it just gets under my skin because like obviously he has a right to not get vaccinated, but he doesn't have a right to like be rude to me for getting vaccinated. You know what I mean? Like
Yeah. No, I hear you. I hear you. Yeah, some of these are really good questions. Yeah, this is good stuff. Okay. Yeah, so that's essentially how I would tweak essentially these types of questions. So, Bree, I'm going to sign off. Thanks for spending time with us this evening. Study hard, make me proud, okay, Bree?
thank you.
Thank you.
Good night.